Hi, I'm Sophia Lannon. I'm one of the perinatologists at Northwest Perinatal, and I'm presenting magnesium sulfate in obstetrics uses and abuses as part of the Northwest Perinatal MEDx series. So the objectives for this talk are magnesium sulfate's uses in obstetrics, a few cautions, and then I'll conclude with a few pearls. There are essentially three uses for magnesium sulfate in obstetrics. Seizure prophylaxis in the setting of gestational hypertension and preeclampsia, fetal neuroprotection for preterm deliveries, and tocolysis. Let's start with seizure prophylaxis. So in 2013, ACOG came out with a hypertension and pregnancy bulletin. It's very dense. It has a lot of information, and it's a great reference in case you're stuck with how to manage preeclampsia or any form of gestational hypertension and pregnancy. Indications for when to give it are essentially when you have any form of preeclampsia, gestational hypertension, or chronic hypertension with superimposed preeclampsia and severe features. The severe features are similar for the different types of hypertension, but that's the key component. And no longer are we using magnesium sulfate for seizure prophylaxis in mild disease. When to give it? Well, we administer it during labor, continue it through the C-section, and then 24 hours postpartum. We stop it in women that we decide to expectantly manage. So an example of that would be somebody comes in at 33 weeks gestation. She's got severe range blood pressures. You're evaluating her for severe preeclampsia. And you give her some antihypertensives. Let's say she has a headache as well. You give her magnesium sulfate for seizure prophylaxis. You draw some labs, you do your workup, and after some time, you get your results back. Her headache's improved as her blood pressures come down. You've been successful in getting some control of her blood pressures, and you decide that you're going to try to expectantly manage her until 34 weeks. At that time, you should actually stop the magnesium sulfate. So there's not a prescribed 24 or 48 hours of magnesium for seizure prophylaxis in the setting of severe preeclampsia. That's expectantly managed. Dosing is different for prevention and for treatment. Prevention dosing and Northwest Perinatal standardly gives 4 grams of a loading dose and 2 grams per hour. Randomized control trials have also shown that 4 grams loading dose with 1 gram an hour continuous rate is effective at seizure prophylaxis. And so if your patient is very symptomatic from 2 grams an hour, it is okay to decrease that rate. Treatment doses of actual seizures are different. So the loading dose is higher, and you start with a 6 gram loading dose and continue at 2 grams an hour. If you don't have IV access, you can also give it intramuscularly, and that's 3 grams in each gluteus. I just want to take a moment to talk about magnesium levels. So in the normal state without any supplementation, a normal magnesium level is 1.5 to 2.5. The targets for seizure prophylaxis is 3.5 to 7, and you start to see symptoms of toxicity at 8 to 10 with areflexia, and you can have cardiac arrest at 13. So the caveat to this, though, is that you can have seizure prophylaxis even if you're not in the target range, and you could potentially not adequately treat an eclamptic seizure if you're in the target range. So these levels are actually not very useful, and we don't standardly order levels for magnesium at Northwest Perinatal because it really doesn't help you clinically very well. Toxicity can be evaluated clinically as well. So let's switch gears to fetal neuroprotection. This was first observed by providers who were using magnesium for other indications. They noticed that babies born to moms who are on magnesium seemed to do a little bit better from a neurologic perspective. So randomized controlled trials were performed. There were 3 main ones that were done in the early 2000s. I would like you to take note here that the inclusion criteria are different for these 3 randomized controlled trials. The dose administered is different for the 3 trials, and the duration was highly variable as well. The only study that showed a significant protective effect was the Rouse study that did show a reduction in the risk of cerebral palsy in babies that delivered preterm. So what do you do when you have 3 large studies that have that are looking for a rare outcome and don't show a significant effect? A meta-analysis. And the Cochrane review looked at 5 trials. There are actually 2 other meta-analyses on the topic as well, and they showed similar results. And this meta-analysis did demonstrate a significant effect when you combined all the studies to reduce the risk of cerebral palsy. And the number needed to treat to prevent 1 case was 63. ACOG then came out with a committee opinion that stated that it is worth considering magnesium sulfate for fetal neuroprotection when in deliveries at less than 32 weeks. And they also said that you should have a protocol if you're going to do this, because the dosing is so variable and the duration is so variable. Pick one and go with it. So that's what Northwest Perinatal did. We picked the Rouse study protocol because that's the one that was the biggest study, and it's the one that showed a protective effect in the outcomes. For this protocol, we choose patients who are we include patients that are less than 32 weeks. We use a 6-gram loading dose and then 2 grams per hour and continue it for up to 12 hours. If at that point the patient hasn't delivered, we stop the magnesium sulfate, and then if she does go on to deliver prior to 32 weeks, we resume it. And if it's less than 6 hours since you stopped it, you don't have to repeat the loading dose. So an example of how we might use this in practice is you have a patient who presents who's 30 weeks, for example. She's PPROM'd. You don't necessarily want to tocalize the PPROM patient because of the controversy, and actually ACOG doesn't recommend that we do that. So but you do want to give the neuroprotection. So you give a 6-gram loading dose and continue the magnesium for 12 hours for neuroprotection. If she hasn't delivered at that point, you can stop the magnesium and continue to observe the patient. And if she then all of a sudden is laboring and breech and you're taking her to the OR, you can hang a new bag of magnesium and get her resume the dosing. Okay, switching gears again to tocolysis. We all know that tocolysis is intended to be a short-term prolongation of pregnancy in order to accomplish specific goals. We're not really trying to prolong the pregnancy. Those goals include betamethasone course, magnesium for neuroprotection, and transport to a tertiary facility. The first-line agents for tocolysis are beta agonists, calcium channel blockers, and NSAIDs. Magnesium is a second-line agent due to maternal side effects. So how do we make sense of all this when magnesium is a medication used for fetal neuroprotection, but it's not a first-line tocolytic? Well, we're in the practice of using for starting with magnesium in women who present with preterm labor at less than 32 weeks because it has a double effect of both tocolysis and fetal neuroprotection. Once you reach 12 hours and have completed your fetal neuroprotection but have not, but still need potentially some tocolysis and haven't completed your steroid window, you can reevaluate the patient and decide if she's having significant side effects that require switching tocolytic agents. You could stop tocolysis if the patient is doing well and hasn't had any contractions and was not super threatening to begin with. You could, or you could initially start with 2 agents like magnesium and indomethacin and intentionally stop the magnesium because your 12 hours of neuroprotection is over, and continue the indomethacin for the full 48-hour course. At 32 weeks or greater, we do not use magnesium for tocolysis. We use calcium channel blockers as our primary first-line agent, so nifedipine, for example. A few cautions for use of magnesium. There are a lot of side effects. We've all seen them: flushing, diaphoresis, nausea, areflexia. Some are really severe, like respiratory depression and cardiac arrest. And there are also neonatal side effects, like neonatal depression. If you encounter these, the correct response is either to stop the magnesium or to turn down the rate, depending on the severity and the indication. It's also important to know that the FDA has changed the category of magnesium sulfate from A to D, and it warns against the use of magnesium for more than 5 to 7 days to stop preterm labor. This is because of fetal and neonatal bone demineralization and fractures that have been noted in women with prolonged use. Okay, to summarize a little bit, appropriate and inappropriate uses for magnesium sulfate. So it is appropriate to use magnesium sulfate for seizure prophylaxis in women who have severe features to their gestational hypertension or preeclampsia. If they do not, and it's mild disease, it is currently inappropriate to use magnesium for neuroprotection, or for seizure prophylaxis, sorry. It is appropriate to use magnesium sulfate for the treatment of eclampsia, and it is a first-line agent and is far superior to other agents. It is inappropriate to continue magnesium sulfate in women who you are expectantly managing for severe preeclampsia. For neuroprotection, appropriate less than 32 weeks, inappropriate for 32 weeks and greater. Tocolysis, same thing, inappropriate for less than 32 weeks, appropriate for 32 weeks or greater.
You mean, yeah, the other way around.
Oh, I'm sorry. Tocolysis, inappropriate, appropriate for less than 32 weeks, and inappropriate for 32 weeks or greater. I'm sorry. Okay, this concludes my talk, and I'm happy to take questions.